Go ahead.
Thank you, Yasser and Gani, for the introduction and for organizing the virtual workshop for the lung ultrasound. And welcome, everyone. I hope you will enjoy the presentation. Can everyone see the slide and can hear me clear?
Yes.
Perfect. So as Yasser mentioned, we'll give overall in this session the basics of lung ultrasound. So, but you'll have the opportunity when you go to different station to hear more about each part of what I'm going to talk about. So we have only 30 minutes. I have nothing to disclose. My objectives is to discuss with you why lung ultrasound. We knew that there is X-ray for over a century now. So why lung ultrasound now? What's the advantage? How to perform lung ultrasound? How to identify the normal and abnormal lung ultrasound pattern? And how to assess the lung aeration using lung ultrasound score. Then we'll conclude with one slide with the applications of lung ultrasound in the NICU. So why lung ultrasounds? We knew that ultrasound in general, not only lung, any type of ultrasound is a safe imaging modality compared to the other modalities, especially the X-ray and CT. Ultrasound in general is low cost, is portable. So this is your new stethoscope. You can carry it from bed to bed and you can examine your patient and assess, then you can go back and reassess again after you do any intervention. You can do continuous monitoring of your patient by yourself. So you are the physician who's taking care of the patient, you know the clinical background, you see what's going on in the lung, you do your therapy, you go back and recheck. So there is continuity of the monitoring using lung ultrasound. It is a rapid test. Once you learn the lung ultrasound, it usually takes from 2 to 3 minutes. And I'm not exaggerating, 2 to 3 minutes for you to finish scanning right and left lung, unless you do extra. Diaphragmatic assessment or upper airway, this is not counted in this 2 to 3 minutes. It is a very sensitive tool for early detection of different lung diseases. And this is a little bit history. So until 1992, and this is a textbook from internal medicine, who actually the pioneer for lung ultrasound. We inherited lung ultrasound from the adult population. But until very recent, until this age, this is a quote, this part is a quote from this textbook saying lung ultrasound is a major obstacle for the use of ultrasound at the thoracic level. And hence, lung is not suitable for ultrasound. And this was proven to be wrong. Over this three decades, the last 3 decades, we have lots of evidence to say that lung ultrasound is beneficial. It helps, and actually, it, as I mentioned, is more sensitive than the traditional X-ray. The first graph here is indicating it, and this is from adult population, the progressive increase in the utility and use and publications reflected by the publications about lung ultrasound. And this is a study was conducted in 2018 by a group from Italy and shows the publication compared to 2006, 2016. And I did my own search for 2020 and I found more than 170 papers published in 1 year. So that the people now are using more and more lung ultrasound. But as a beginner, to start with, to learn more about the evidence behind recommending point of care lung ultrasounds, I will suggest for you 2 papers. The first one that was published in 2012 by a group of experts in lung ultrasounds who examined the evidence behind lung ultrasound not only in neonates. So in this paper, you will see the utility of lung ultrasound in adult population, pediatric, and in neonate too. But more recently, Yogan and his group in Europe published the international evidence-based guideline on point-of-care lung ultrasound in neonates and children. So in this paper is not only lung. So this group is more focused on holistic, like the focus in general, like head, heart, lung, the abdomen, and vascular, the 5 types of point of care. And they came up with a recommendation. They grade the recommendation with the level of agreement between these experts who wrote this paper and the quality of the evidence. And I cut for you here the 11 indications they mentioned for utility of lung ultrasound with a very good agreement and a very high quality of evidence. The indication was RDS, TTN, pneumonia, ARDS, meconium aspiration syndrome, bronchiolitis, pneumothorax, tension pneumothorax, pleural effusion, for intervention like guide thoracocentesis, and evaluation of lung edema and atelectasis. Each one of this one, they mentioned the publication. Remember, this was published 2020, so more publication happened after this paper. Another paper that was published in 2019 by a group from Italy. Again, I like this paper because it summarized the sensitivity and specificity of different lung disease that we usually see in our day-to-day practice in the NICU, from RDS, TTN, pneumonia, congenital diaphragmatic hernia, meconium aspiration syndrome, pneumothorax, pleural effusion, and congenital malformation of the lung. And as you can see, the sensitivity is extremely high. Specificity is also high. More important for me, the agreement between the different operators. So even with short experience, as long as you fulfill the criteria that we will indicate at some point, how many scans you need to do in order to be able to perform lung ultrasound, once you fulfill this criteria, there will not be much difference of your interpretation with someone who's doing lung ultrasound for years. And the interreliability or correlation between different operator, again, is extremely high compared to different modalities. Let's agree before we start our workshop that the lung ultrasound is different. Different from what? Different from other types of ultrasounds. So if you are familiar with the abdominal ultrasound, this is part of abdominal ultrasound. You can see the liver, kidney, the diaphragm, and the lung, part of the lung in here. And it's easy to bring a junior person and explain to him or her the different organs. Again, if you are familiar with echo, this is what you will see, which will be exactly corresponding to the anatomical structure of the heart. This is not the case when it comes to the lung. If I will tell you that this is a still image of a normal lung, you might be surprised if you never heard about this one. In the subsequent slide, this one will make sense for you. What I showed you as just bamboo or transverse lines, how this is represent a normal, well-aerated lung. Let's agree that the lung ultrasound will give you two components. Will give you, similar to other ultrasound, similar to the abdominal ultrasound, anatomical structure that corresponding to the actual structure in the chest, and another half will be artifacts, means is not real anatomy. The part which is anatomy starts from the skin, subcutaneous tissue, pectoralis muscle, the ribs, the intercostal muscles, down to the pleura. You will see this one, and it should be more or less the same as the anatomy as it in the chest. When it comes down to the parenchyma, the story will be different, where you will not see, like in the right lung, the upper, middle, and lower lobes. You will see artifacts. Could be what we call A line, B line, C artifacts, which is easy now that we link this artifact to what's going on in the lung itself. So for you to know how this is the artifacts happened and what the explanation behind, I will share with you. There is 2 slides. I will skip one for the sake of the time, about the physics of the ultrasound, which is applicable to any ultrasound. So sorry that I skipped the first one for the sake of the time, but this is the most important one. Which is the how the lung ultrasound or ultrasound in general go through different tissue. I need you to understand this one very well because it will help you to explain all the artifacts and it will make sense for you. If the ultrasound go through a fluid part, which is the upper part for the 3 here, which represent the gel that we bought, it will go through very easily. Then it depends. If the media below is mainly or predominantly contain air, then all the waves will be reflected back. And this is what will be represented here. So what you see is skin subcutaneous tissue, as I mentioned. This part represent the reps, and this is the pleura. The first echogenic, very white line here is a pleura. Because all the waves will go back, you will not see anything past the point of the pleura. So what about this part? What I'm seeing here? What you are seeing here is repetition for the pleural line. Just repetition, because this is a pulse wave. The first wave will give you a pleural line. The second will draw exactly the same, but we call the subsequent line A line. We'll explain it when we come to the A lines. But this will be different if the media below the skin is predominantly contain liquid or fluid. Then the ultrasound wave will go through and bend. If this is only interstitial, means not in the alveoli, then you will have a comet tail, or what we call the B line, longitudinal this time, not transverse as here, and we call this one the B lines, which will be separated. If the fluid become more and more to include also the alveoli, so we have now interstitial and alveolar edema, then this separated B line will be condensed B line. And if it progresses more to the point that there is no more air is zero, and everything is replaced with fluid, as in case of pneumonia, this is how it will look like. Okay. What about the bone? Because in your scanning for the chest, you will face bone too. So you might face air, you might face liquid in the lung, but the bone will come even before this too. And as simple as this way, the bone will give you a shadow behind. So this is the black line that you are seeing here is not inside the lung. This is just the shadow of this reps. And no, I will not spend much time in here because you will hear this one again in other sessions. So a few principles or facts for lung ultrasound, that ultrasound does not transmit through aerated tissue, period. And this is applicable anywhere, by the way, not only the lung. So if you are doing abdominal ultrasound and the baby have distended bowel, same rule applied. Interface between the pleura and lung parenchyma, this interface, wherever there is interface means fluid containing area and air containing area, this interface always give you a very echogenic bright line. And you are not seeing the parenchyma as I mentioned before, but it will be represented in normal lung with A lines. And remember, you are seeing the lung in a very narrow acoustic window, which will be the intercostal space. Remember that the bone will give you shadow. So what you are seeing the lung in between the intercostal spaces. How to perform lung ultrasound? First, you need to choose your probe. And the curvilinear probe in general is called the universal probe. Means if you don't have, but the curvilinear, it's fine to do the lung ultrasound. And it can do any types of point of care ultrasound. However, when it comes to the lung, we prefer the linear probe because of the high frequency. This is a very high frequency that give you better resolution and better delineation of the pathology in the lung. There's two types of the linear probe. This one, which is the most common, what we are using in Sinai, yes, it is using in Winnipeg and Gani in McMaster, but is not a bad idea that if you have the huck stick exactly the same, you can use it. This is the linear one that you can use it for the lung, for vascular, any superficial organ, you can use the linear probe. What about the machine? Machine is a good news that lung ultrasound does not necessitate a sophisticated ultrasound machine, similar to the echo, where you need a more filter for the scan. So any point of care ultrasound should be okay to do the lung ultrasound, as long as you turn off the noise filter, because you need to see the artifacts. In lung ultrasound, you are dependent on seeing the artifacts. And this is usually the representative of the company will help you to preset, make a preset for lung. But if you don't have, and you have one for abdomen, should be fine. Both of them work fine for lung ultrasounds. What about the zones? Where I'm going to put the probe on the chest of the baby. There is the standard or the minimum areas that you have to scan, and there is extended lung ultrasound scan. The minimum areas that you have to scan, if the baby is in supine position, then it will be the anterior, upper and lower, and the lateral, and same on the left side. And which here will be the lateral mid-axillary. You do the scan this one on the right and left. But if your patient is in prone position, we tend not to change the position for many reasons. First, not to disturb. Second, it affects your reading, and we can explain this one more when you go to the different stations. But basically, you do 3 zones on the right side: anterior upper, anterior lower. This is 2. And lateral will be the 3rd one, and you do 3 again on the left side, which will give you 6 zones that you need to report. If you need to extend this one because you are worried about pathology on the posterior part of the lung or the basis of the lung, we always recommend that you keep the baby in the new position. So if the baby was supine and now turn it to prone, to keep the baby for at least an hour in this position before you repeat the scan. Otherwise, you will have a little bit higher score, because this is the dependent area where more fluid will be in. How you position the probe? You position the probe in one of 2. The classic one is the longitudinal, where the pointer looking toward the head of the patient. But I always try to use both directions so we don't miss any pathology, especially if you see an area of atelectasis or pneumonia. It's better to do the 2 directions, so you cover the lung from different areas. This is illustrate what we already discussed. Again, one of the beauty of the lung ultrasound that you can perform it while parents are holding. You don't have to take the baby to the bed to do lung ultrasounds, even if the baby is still on some oxygen. With this one, I prepared question, but I might skip the questions again for the same reason, for sake of the time. What about the basic signs that you will see? Now we learned it, which probe, which machine, where to put the probe on the chest, what you will be seeing in different lung pathology. The first part I need to share with you is you have to identify the landmarks for lung ultrasound. What's the landmarks? The landmarks are, the minimum is you capture a rib, 2 ribs, 1 upper, 1 lower, and at least one intercostal space. In neonate, this is not a problem because the chest for babies are small, and your probe usually cover multiple, as you can see here, multiple intercostal spaces and more than 1 rib. Definitely the 3rd one comes and goes in here. So this is not a problem, and we discuss what structure you will be going through when you do the scan itself. The first sign, which again describe the landmarks, is called bad sign. Bad sign has no significance as a sign by itself. To say I saw bad sign, what it means? More than it tell you that you are putting your probe in the proper position. Your probe is in a good position. Now you can comment on the finding. Otherwise, you will miss a lot of the finding. So again, the bad sign means you have upper rib, which is here, this white line represents the rib because this is cartilage still. And the second rib, which is the lower rib, again, white line, and the pleural line in between, as if this is represent the body of the bat, and the 2 wings are represented by the 2 ribs. Again, this is just to put you, to ensure that you are putting your probe in a good position. Sorry. What about the pleura itself? As you know, the lung pleura is 2-layered. But these two layers, there is no ultrasound so far, at least with the one we have in here, that can give you the two layers separated from each other and sliding in opposite directions, as you will see in this demo video. However, what we will see is both layers will be as if they combined and give you one, as I mentioned, echogenic bright line, especially if the lung is well aerated, that's sliding from side to side, as you can see again in this demo. So you will not see two lines, you will see one line. Again, this is in real. You see here the pleural line and is sliding. We'll talk about this one more when we see more videos about this one. What's the importance of this pleural line? First, you have it is a structure that's always in motion because the lung is always slide during breathing. It moves with respiratory cycle. Presence of sliding means no pneumothorax. It's done. You rule out a major emergency situation if you are familiar and you can differentiate between pleural line sliding or no sliding. Absence of sliding could be pneumothorax, but it could be also a big atelectasis, big pneumonia, or the baby or the patient in general, even in adults and children, is apneic. If you hold your breath and you scan, definitely the lung will not be sliding and you will not see the sliding in this situation. What about the A lines? The A lines, we already discussed this one and we'll discuss it also in the first session. It's simply the replication of the pleural line. And what this means that this lung is well aerated. Because we already discussed this one in the physics, the waves will go through to the pleura. There is fluid in the pleura. It will go through it, but once it sees that the lung is well aerated, all the waves will go back. And this is will drive for you, or draw for you this pleural line. With the subsequent waves that comes afterward, you will start to see more and more repetition of the pleural line, what we call the A line. They are equidistant, and they represent the time that the ultrasound wave take from the skin to the pleural line. Same distance here will be exactly between this two and goes all the way down to the base of your frame. So if we need to summarize what normal from what we already discussed so far, you can now go to level 1, or a baby who admitted to your unit for phototherapy, not on respiratory support, no breathing issue, and if you scan, now you know how to say that this is normal lung ultrasound by this 3 finding. If you see the pleura is sliding, there is A lines artifact that we described. You may see 1 to 2 B lines, and I'm going to explain to you how the B line is formed, but this is still considered part of the normal. If it becomes more than 2 B lines, there is something pathological here. And I need to just give you a quick hint for babies who are transitioning, like just deliver now, even if they are full term, they might have multiple B line. This is part of their transition, as long as they don't have actual respiratory distress. So don't overcall the babies based on the ultrasound. Ultrasound should be incorporated in your overall assessment of your patient. You don't treat the lung ultrasound, you treat your patient. Focus with the patient overall, what's going on. Then use the lung ultrasound as a tool to help you narrow your differential for your patient. Same for when you do preterm babies, expect to see B lines, because this is part of their immaturity, and immature lung does not mean that there is something not going well with this patient. What about the, yes, okay. So here we discussed the normal, but if there is no sliding, what will be happening underneath? What kind of artifact if there is no sliding? And here I'm bringing the pneumothorax as example. And as you know, where is the pneumothorax? Where it happened? Between the 2 layers of the pleura. So it separates for you the parietal pleura and make it distant from the visceral pleura. So you will never be able to see the sliding because the air in between will prevent the waves from crossing down to the visceral pleura. So what you will see is kind of only the parietal pleura, which will be still echogenic in here, and you will, because the air now become 100% air. In normal lung is not 100%, might be 90% air, 10% tissue, but in pneumothorax is 100% air. So all the waves will be reflected back. So besides the sign of no sliding, beside the sign no sliding, there will be tons of repetition of the A lines. You need to do another test to confirm that this is pneumothorax and no sliding, which is using the M mode. And you put the M mode and make sure you don't put it on the rib. You put it in the between the ribs, so in the intercostal space, because this will measure for you the motion at this area. If there is no motion, it will be straight lines. And this is what you will see in this video. So it's very silent. And you can imagine this baby, by the way, because from my unit, it was in HFO. So like tons of shaking, but you see the lung inside is very silent because of the pneumothorax, and you will not miss this one. If you do the M mode, it will look like it will look like a barcode. This is the real one. This is just barcode. I put it for illustration. So how it will look like if you do M mode in a baby that does not have pneumothorax, you will see what we call the seashore sign, which is parallel line for the static part of your scan, which is the subcutaneous tissue, but the rest of the lung, because there is a sliding, there is movement of this lung, you will see it as a sandy looking part. This combination, we call it seashore sign, which reassure you that there is no pneumothorax. Again, we'll skip all the questions for the sake of the time. B line artifacts. So far, we spoke about the pleural line, how it looks like, what it means. We spoke about the A lines in normal lung and in pneumothorax too. B lines is different, and B, remember, this is from bad. So there is something wrong with this lung, as I mentioned, unless the baby is still transitioning or very premature baby. So what's B line means? Mean that there is fluid in the lung that is become predominant now, more than the air. It displaces the air and become fluid. And we have different fluid, as you know, in the lung. Could be only interstitial, could be interstitial and alveolar, or could be generalized edema in the lung. So in the first scenario, if the fluid is only in the interstitial, you will see this laser like rays or the comet tail B lines, longitudinal echogenic line coming down from the pleura all the way to the bottom of your screen. This is the represent the interstitial. What about this one? This is what I was referring to as a normal lung, when you see only one or two B line in your frame. This is represent interstitial lung edema, and when these lines combine together and become different to differentiate them, this is what we call the condensed B lines. Two types, separated and condensed. We'll skip here because of the sake of the time. I have another 5 minutes to finish this one. So can I see A and B lines together in one frame? Yes, in many conditions, but the most famous one is the TTN, where you can see what we call double lung point. You see area of the lung that will aerated, an area of the lung still congested. And as I mentioned, best example is TTN. If you run this video, nice sliding, A lines, well aerated part, and B lines, less aerated part. It's absolutely fine. And we'll explain this one when you come to the session of the A and B lines. Question, consolidation. Another session you will have today about consolidation. So quick glance on the difference between atelectasis and pneumonia. But remember, this is a very conflicting part. Lung ultrasound can help you to say that is most probably pneumonia, most probably atelectasis. This case is black and white, like this case that I brought for you here. This is pneumonia. You see, this is the liver, this is the lung, and you'll have more detail why it looks like this way. But you can see very easily that the texture of the lung here is exactly the same as the liver. what we call hepatization of the lung. And you don't see the pleural line, which is supposed to be in this area. It is not displaced, still there, but is part of the pneumonia now. Compared to the atelectasis, where you see it like more slightly echogenic compared to the pneumonia part. You have the air bronchogram, and usually, especially with good support, it will get collapsed during expiration and open during inspiration. And this is the beauty when you do a clip rather than a still picture. So you see it between, you see it become more dots, you see it in between. See, like in this one, here and here. And if you focus on this part of the lung, in a second, it will be whitish, means all this atelectasis opened up. And this is usually during the inspiration. So this goes more with atelectasis. Pneumonia will not open and close, okay? But again, it's not as this simple, and you need some level of experience to differentiate between the two. Again, same, showing during expiration and inspiration. And another case for the pneumonia. Sorry guys, if we skip some of the slides, but you will have all this in detail in your session. What about chronic lung disease, which is most of our babies in the unit are actually from this category. And I will summarize this one from what I like to call mixed lung pattern. So all what we discussed before can be in chronic lung disease. So the pleural line itself will not appear normal. Most of the time it will be thick and irregular, and you will have what we call atelectasis or subpleural atelectasis below the pleural line that could be of different size. Could be small, could be big, but this will be your landmarks that this baby start to have early changes for chronic lung disease. Many publication already is out talking about the early prediction of chronic lung disease using lung ultrasound. Very, very, very promising tool, and it actually have good sensitivity and specificity in the first 3 days or even 7 days of life to predict BBD. What about the lung parenchyma itself? As I mentioned, homogeneous. You will see B line, maybe an area of hyperinflation that have A lines and areas of consolidation. We use this lung severity score to assess and estimate the severity of the pathology. And this will be kind of summary for what we discussed. If you move more from well-aerated lung to almost zero air and 100% fluids, so you move from A line pattern to the B line pattern to the condensed B line to the hepatization of the lung. What about the lung ultrasound score? In lung ultrasound score, there is 4 patterns that we use to score any lung from the A line pattern, which you score it as 0, to the separated B line, which you score it as 1. If the B lines are condensed, you score it as 2. And if you have area of atelectasis, especially if this area more than 0.5 centimeter or more than 5 millimeter, then this is significant enough that you score this patient as 3. The total score is 18, but any patient can be either 0 for all the areas like this one, or can be 18 if all the areas will be from this severe end. This is how we report it in Sinai, but different shape and different ways of reporting is acceptable too. What about effusion? Can lung ultrasound help me with effusion? Absolutely. Especially if there is a small amount of effusion, then the sensitivity of the X-ray is extremely low compared to lung ultrasound, which can predict few milliliters of fluid in the lung. The best area to get this one will be the R4 that we explained it there, or L4, which is the costophrenic angle. And in this video, you see this anechoic black area. This is the area of effusion with the lung collapsed and floating inside this fluid. We call this one the jellyfish sign. This is the liver and this is the spine. Same baby after we drain the effusion. You see the area completely closed. Liver is here. This is the diaphragm, the lung, and the spine, and no collection of fluid in between. Very easy. 1 minute you need, and you know if your baby that you are resuscitating in the resus room has pleural effusion or not, as part of the reason for the baby is having study stress. I'm saying this one because I have a couple of babies that I use the machine in the resus room to quickly see if there is still effusion in or no effusion. And we should proceed with the regular management. Another sign, not important, mirrored rep sign for pneumothorax. We can explain it further in the other sessions. Important sign, actually, very pathognomonic for localized pneumothorax. If your probe is crossing between area of pneumothorax and area of lung that does not have pneumothorax, if your probe is crossing this area, what you will see? You will see the two. The lung will reflect for you what's in here. So the part with the pneumonia, this upper part here, will be represented with this part. Look at how silent this part. This movement, rocky movement, is because of the heart pulse. There's no sliding. You see some like rocky movement here for the pulse compared to very nice sliding in here, which represent this part. So absence of sliding part, the area in between is called lung point, very pathognomonic for localized pneumothorax. This is my last slide, which summarizes the application of lung ultrasound. What indication I can use lung ultrasound for in the ICU. I divided two: diagnostic, guidance, early prediction, and reduce radiation exposure. For diagnostic, can diagnose RDS, TTN, pneumothorax, consolidation, pneumonia, pleural effusion, as I show you, a congenital malformation of the lung. We have one case, but we can share it. I'm not sure if we don't have a chance today, but this is very, very rare that you see, but is already known as indication for utility of lung ultrasound. Guidance of intervention, most common I use in my unit. I would say the three, but the first one is more or less on a daily basis. The ultrasound guided lung recruitment is extremely important. Guide your pleural effusion, drainage, pneumothorax aspiration, early prediction of surfactant therapy, lots of publication. Lung ultrasound can predict non-invasive ventilation failure. Lung ultrasound can also predict clearance of lung fluid in babies with TTN, so you can decide if your babies are improving and can go to the floor or stay. And I already mentioned the early prediction of BBD. Definitely, and think of this one, we are not here, I'm not here, I'll talk about myself, I'm not here talking about replacing all the x-rays with lung ultrasound. We are not there yet. It needs manpower, you need people who are expert, you need to be around all the time in the unit. It's not impossible, but at least reduce your baby from being exposed to lots of unnecessarily x-ray, especially if you have a tool that will not give you less information than the x-ray. In most of the occasion will give you more and more information about what's going on in the lung of your patient. With this one, I'll conclude with the limitation of the lung ultrasound, that lung ultrasound is limited to whatever the lung can see beyond the pleural line. Remember that you are seeing between the reps, neonates usually their chest is shaking, so you need to know how to hold your probe in a stable position. And it is operator dependent, depending on your level of experience, but all the publication indicated that lung ultrasound is the fastest learning curve compared to different point of care ultrasounds. We already discussed this one. Thank you so much. Wow, we talk all the time.
Yeah, no problem. Thank you, Adil, for the fantastic overall, very comprehensive review of lung ultrasound in your presentation. That's very good preparation for all of the stations. Yeah, we had